मैं डॉक्टर पूनम गोयल हूँ। मैं मैक्स हॉस्पिटल में बैठती हूँ एज ए गायनेकोलॉजिस्ट और मेरा अपना भी हॉस्पिटल है। पिछले 35 इयर्स से मैं गायनी एंड ऑब्स्टेट्रिक्स का काम कर रही हूँ। टुडे वी विल टॉक ऑन जेस्टेशनल डायबिटीज। That from doctor's point of view as well as from patient's point of view. So as we all know that India is taken as biggest capital of diabetes mellitus in the whole world. Western world has 2 to 3% of gestational diabetes mellitus, whereas in India the incidence goes up to 17%. And you will be surprised to know that in North India, the incidence is much more. It's around 25%. And if you take alone the Punjab, state of Punjab, it has the incidence of 28%. It's really surprising why this is so. It all is related to our sedentary lifestyle, our food habits which are not good. Gestational diabetes mellitus is when you develop diabetes during the state of pregnancy. You are not diabetic earlier and you will not be diabetic after the pregnancy, though there are 10% chances of you becoming diabetic after bearing the pregnancy. Actually, pregnancy is not a state of a disease or it's not a pathology. It is a physiological change in your body wherein your body is working under stress. Because of that stress, diabetes is there. Like you have seen in many cases, like in Corona now, you must have seen or you must have listened from here and there that the patient developed diabetes during the treatment of COVID or during the state of COVID. Similarly, because the body was under the stress, that is why they developed diabetic. These patients are kind of pre-diabetics, and whenever there is some stress on the body, they will become frank diabetic for that temporary phase. So now coming on to why the incidence is so high in northern India, because I think our food habits are relatively different from that of southern India, and it's entirely different from the western countries. They only take salads and just saute food without any chapatis and all, but where in our food it doesn't go without chapatis. So these chapatis or the carbohydrates which we take, everything will turn out to be sugar ultimately. It's not that I have to take chini or the sugar only. If I take carbohydrates, it's as good as taking sugar. Whenever the patient comes, every patient in our antenatal clinic for the first visit, there is a universal protocol of doing OGTT. OGTT is that we do oral glucose tolerance test. We don't wait the patient to be fasting. Whatever she has already taken, it doesn't matter. She is given a load of 75 grams of glucose and sugar is tested after 2 hours. So that is our OGTT. If the levels are coming out to be more than 140, then we have to take HbA1c and then see whether the patient is diabetic earlier also or not. Or if the levels are coming out to be 125 and between 125 to 140, we have to be little more careful in these patients. We can just give them nutritional advice and follow them later on. And if it comes out to be less than 125, we are okay with it. And another thing, whenever the patient is diabetic pre-diabetic and embarking on the pregnancy, in these particular patients, we must test their HbA1c. If HbA1c is more than 6.5, maximum up to you can go up to the limit of 7, never more than 7. but ideally it should be 6.5, because if the patient embarks on HbA1c higher levels and then embarks on pregnancy, then there are very much high chances of getting congenital anomalies in these particular patients, and we have to be very careful in these patients and we need fetal echo also, and close monitoring and a good resolution level 2 scan, not the routine ones which we get in India. A good level 2 scan for these particular patients, that is very important. And then after this we do a first OGTT, then we do, if the patient is low risk, then we do next test we do at 24 weeks, then next we do at 32 weeks. If while we are scanning or in our clinical judgment in any point of time, if we find that Liker is going towards higher side, then we again need to do the test. Or there is a family history, like her mother and her father both are diabetic, and the patient's brother or sister, or she had a macrosomic baby in her first pregnancy, these particular patients, then after 28 weeks of gestation, I think we should monthly do her OGTT test to find out the GDM presence in these particular patients. What is the bad thing about having GDM or having diabetes? What's the bad thing? Bad thing is that this is kind of a precursor for the metabolic disease, and metabolic disease is if 3 things are present out of the 5 things, like one is your BP more than 130 by 85, your blood sugar levels fasting more than 110, postprandial more than 140. Then 2 things come from your lipid profile, that is your HDL levels, which is a protective or good cholesterol, that is less than 35, which we need to be more than 50 most of the times. But if it is less than 35, it is not good for us. And your triglyceride levels are more than 150. So these are the 4 things. And the 5th one is that your waist circumference is very high. It means that twice your waist circumference is more than the height of the body. So if any 3 things are present out of these 5 things, then you are having a metabolic disorder. And this metabolic disorder, I remind you that it is a precursor of 150 diseases. It's really unbelievable, but this is the fact. And these 150 diseases, I would say most of them are neurological. Like you may have Alzheimer's, and then you may have cardiac problems also. If they are not neurological, they have cardiac problems. There are CVA attacks, there is paralytic attacks. So we need to protect our body, we need to change our lifestyle. And whenever you are gestational diabetic, there are so many bad things for your baby. First and foremost is that there is fetal death inside the mother's womb. That is because of some factors which we will eventually discuss. There is silent stillbirth. That means the yesterday morning or the today morning the baby was moving well, and suddenly you will feel that baby is not having movement, and by the time you go to the doctor, the baby is already gone. And other things, if the baby survives, most of the times these babies are macrosomic. Macrosomic means they are having larger weight. For India, we consider it more than 3.8 kgs. And if the baby is macrosomic, then these babies are eventually a precursor of developing diseases in their lifetime. When they are when they grow up, these babies, they may become obese. These babies, they may have diabetes, and then they may have these metabolic disorders also, which we were discussing. They may have high BP. So many diseases these babies can carry with them from the mother's womb. Visceral fat, which in some time back we were thinking that there is no role of visceral fat, but now it has clearly been proved that visceral fat is not good. Sometimes there is another thing also, that sometimes the mothers are diabetic earlier, and when they carry on to the pregnancy, or when they become pregnant, they were diabetic earlier also. If I see 100 patients with having diabetes during pregnancy, 10 patients will be pre-diabetic who are coming with pregnancy, and 90 will be those who developed the diabetes during their phase of pregnancy. What happens in GDM? GDM, there is insulin resistance. There is body doesn't use the insulin which is there, because the amount of sugars are so much high in the blood. So that is why there is deposition of glycogen in the body. And same way in the baby also, what happens, that mother is diabetic but the baby is not. And when the mother has blood sugar high levels, the baby will eventually form more of insulin. This hyperinsulinemia, it creates deposition of glycogen in baby's liver. Insulin is considered as a good growth factor. So that is why there is macrosomia in the baby. So we were discussing fetal complications. One we discussed that there is a possibility of stillbirth in the fetus, and why this stillbirth happens. Stillbirth happens because the requirement of the baby is very high, because the baby is already macrosomic, so they require more amount of oxygen, and where in the mother the hemoglobin becomes glycosylated because of the presence of high glucose level in the blood. So oxygen carrying capacity of blood decreases with time, and there are many changes in the placenta also, and all these eventually leads to disbalance between the requirement of the baby and what is being provided to the baby. So slowly, very slowly the baby will become hypoxic, and ultimately there is fetal death. And if the fetus grows, then they become macrosomic, and if there is any mother also has very many complications. Like if the baby is macrosomic and mother is giving birth to a baby who is having a larger weight, there are many complications, like there are bleeding problems at the time of the delivery, and sometimes there is shoulder dystocia also, that is there is obstruction in the delivery, and the chances of operation also becomes very high, that is cesarean, very high because of the weight of the baby. And post-operative also, mother is liable to have more of infections, and there are more of anesthesia complications also in the mother. There is sometimes rupture of membranes, that is too early, that is preterm rupture of membranes can occur. And in very few cases there is no macrosomia, but there is fetal growth reduction. That is, the fetus grows less as compared to the normal growth of the fetus, because the oxygen supply or the blood supply to the baby is very less because of the gross changes in the placenta. So that is why I would say that whenever the mother is gestationally diabetic, this is not a normal pregnancy, this is throughout a high risk pregnancy. So we have to be very careful. Think what we can do. In all these mothers who are having gestational diabetes mellitus, we should always give a shot of steroid for the lung maturity of the baby, that is to be given at the 30 to 32 weeks of gestation. It should be given. And whenever you will give the dose of steroids, the mother's sugar will become haywire for 48 hours or so, because you have to give 4 doses of Dexona. But you must remember that if you don't give that, then there are chances of baby having RDS, that is respiratory problem after the birth. So if your patient is on insulin, then admit the patient and then give Dexona so that the sugar does not become very high. If the patient is on oral hypoglycemics, then it's okay, you can give the patient, explaining to her that for 2 days your sugar may not be that good as you usually take. Now, what should be the treatment for this? First and foremost is we try to control the blood sugar levels from nutrition, or that is by dietary changes. We have to stop the sugars, we have to stop the carbohydrates, we have to take the low glycemic index foods, like we have to stop, like almost we have to stop wheat. We can shift to ragi, jowar, multigrain atta and besan. All these things, they have low glycemic index. Low glycemic index means that whenever you eat these foods, there is no sudden rise of glucose like it is with wheat and rice, white rice I would say. So the white rice is also not considered to be good. Then foods like potato, and straight away if you eat jalebis and all those mithais, that are also not to be taken. And fruit juices, a big no to fruit juices. You can take some fruits, like you can take apple, that is not very that doesn't have high glycemic index. So one is nutritional control with exercise. Exercise is daily walking patient can does, because in a pregnancy state she cannot do the aggressive workouts like that, but still 30 minutes walk in the morning or 15 to 30 minutes walk in the evening will do. If the patient's sugar levels are not controlled on dietary and this exercise, or basically lifestyle change we would say to this, if the sugar is still not controlled, then we put the patient on metformin. That's a drug which is very freely available in India, and that drug is used for that drug. If the levels or the quantity of the drug goes more than 2 grams to control the sugar levels, then definitely our patient needs to be shifted to insulin. And for shifting the patient to insulin, insulin is given in 2 types. One is a regular dose which works for 24 hours. And then before food, patient has to take insulin before lunch and before dinner. So for that, a gynecologist should always take help of a diabetologist or a physician to put the patient on insulin. And I would say a multidisciplinary approach is always better to treat the patients on GDM. And so these three our mainly our patient on nutritional control, second is on the drug control, and if the drug dose goes more than 2 grams, then we shift the patient on insulin. And whenever the patient is on drug, whenever the patient is on insulin, nutritional and exercise control or the lifestyle change will continue as it is. So that is the management of these patients. And when aggressive monitoring of fetus is also there, because now we have 2 patients, one is mother, one is fetus. So aggressive fetal monitoring, that is from 30 weeks onwards, we will do Dopplers and we will see that blood supply or the Doppler is coming out to be normal. Whenever there is change or there is umbilical artery Doppler reversal or there is any change, then we go and the patient is developing FGR, then we go by the criteria of Barcelona criteria and manage the patient accordingly. In group 1, 2, 3, 4, accordingly we will manage the patient. That we will discuss in our next video, how to go about Doppler changes and then correlating it with the Barcelona protocol. So this is the management of these patients. And then after delivery also, after 6 weeks or so, we again do the test and see whether the patient is now diabetic or whether she has reverted back. And definitely whenever there is delivery, even after 48 or 24 hours of delivery, her requirement of insulin or her requirement of metformin, that usually falls down. But still we have to check after 6 weeks that whether the patient is diabetic or she has become normal. And after that our lifestyle advice will go on so that she doesn't land into diabetes or overweight or obesity, I would say. Now for what is the obesity guidelines for Indians? For Indians it is 2.5 less than the Western world. We are considered to be overweight when our BMI is more than 23, and we are considered to be obese when our BMI is 27.5, whereas for Western world it is considered to be 30. So we, because of our, I think, inheritance, or because of our lifestyle, and because of our food habits which have been going on traditionally for long, we have to be more careful as compared to the Western part.